Okay, welcome everybody. I want to thank organizer for the kind invitation to take part in your conference. This is a topic on obstetric hemorrhage. Obstetric hemorrhage is a leading cause of maternal death. I work in Krakow in University Hospital, providing care to obstetric patients, and it's also one of the challenges that we face. These are my conflict of interest. It's up to the definition which we decide to follow with to assess whether we face or not obstetric hemorrhage. The definitions might be prospective, assessing the blood loss, or retrospective, assessing decrease in hemoglobin level or need for transfusions. Whatever we decide to, we need to be aware that it's a leading cause of maternal mortality, affecting up to 3% of pregnancies. However, when we account the volume of the blood loss, it might be up to 10% of the deliveries, and 2 per 1,000 pregnancies have a life-threatening peripartum hemorrhage, even in high-income countries. Majority, up to 80% of these cases, are the preventable ones. And what we know from different reports, and here is a recent one from the United Kingdom, showing that it's a leading cause of peri-operative cardiac arrest in obstetric patients. There are several risk factors, and when you look at a population of obstetric patients, probably many of them has a risk factor of obstetric hemorrhage, which we might be aware of because anticipating problem really decrease the complications rate. Fortunately, the mother's organisms are fitting well, and they follow the physiological changes, which are also related to the clotting factors, and majority of them has increased concentration at the end of pregnancy. The leading concentration is related to the fibrinogen level, which might be double, even triple at the end of surgery. Simultaneously to that, there is a fibrinolysis, and that's why we got a physiological increase in the dimer levels, which most of the cases should not be treated. There are some clotting factors and proteins which are influencing clotting system, which are the same, and we should expect platelet count decrease, which might be even lower than 100,000, which also covers the risk of increased risk of obstetric hemorrhage. Looking at the reasons of obstetric hemorrhage, the leading cause is a atonia of uterus, and it is responsible for up to 70% of cases of severe bleeding. Second place is covered, it's 1/5 of the cases. Trauma related to laceration, hematoma, or rupture of uterus. Placental complications are those at the third place, and it's a retained placenta, invasive placenta, problems with placentation, which might be very aggressive, generating a high risk of obstetric hemorrhage. I work in a placenta accreta spectrum, and previous cesarean deliveries and uterine procedures, multiple pregnancies are the risk factors. Those patients should be screened during pregnancy just to select them and offer them extra care, anticipating massive life-threatening hemorrhage, which might be related to maternal mortality. Planned delivery, usually preterm babies, but it's the safest way to take care of those patients. We must be aware that most of the cases we are not aware of the blood volume lost, and we underestimate of 30 to 50% of the volume lost. And we need to be aware that the same volume makes a difference according to the size of the patients, because some of them are very obese, some of them are very thin, and we need to calculate the volume of the blood lost according to the weight of the patient. Sometimes we face a patient which faint, collapse after mobilization secondary to hemorrhage that was not noticed, not recognized. We got the tools, and we must be aware of it to use them to calculate risk factors, but also monitoring vital signs. We are able to detect those patients who are deteriorating. Here is an example of the recently published paper on maternity early warning scores, and using this tool, really is helpful for midwives, from obstetricians, some people who take care of patients before anesthetists arrive, to recognize deterioration. Obstetric warning scores are not used worldwide. There are countries with a very low use of those scales. Some have 100% of coverage. This study was also done in Ukraine, and we got feedback from your country, and up to 50% of units taking part in this study declared that use early warning scores, which makes life of the obstetric patients more safe. I will present now guidelines mainly based on the European statement. So the guidelines published in 2023. It is management and treatment of hemorrhage of different reasons, with subchapter focusing on obstetric surgery. These 7 red arrows on the left-hand side indicate strong recommendation when authors of this document use word recommend, which means that we must do it because it influences the patient's outcome. They recommend treating target hemoglobin level during severe bleeding between 7 up to 9 grams per deciliter, and repeated measurement of different elements that we are able to detect and treat. So hemoglobin, hematocrit, lactate level, platelets level, and also look at the clotting factors. Those we can assess and replace. They do recommend the use isotonic crystalloids in a timely and protocol-based manner, not giving too much fluids, which is not good for patients because dilute clotting factors, but have a target, use vasopressors in order to promote good perfusion. Infusion of colloids, it's a labeled way of treating severe bleeding, especially when crystalloids are not effective. However, they may generate and aggravate dilutional coagulopathy and fibrin polymerization, and also influence on platelet aggravation. If there is an uncontrolled massive bleeding, massive transfusion protocols must be used in order to save patients' life. However, if the situation goes stable, the recommendation says to focus on goal-directed transfusion, focusing on a hemoglobin level, clotting factors, and platelets as soon as possible. If there's a severe bleeding, we start a run for life, to obtain a blood sample, send it to the blood bank, send it to the labs to have a feedback and blood back to start a transfusion. And simultaneously to that, we need to activate different other protocols covering proper treatment of obstetric hemorrhage. The guidelines suggest to have a dedicated centers for placenta accreta spectrum, and those patients must be treated with multidisciplinary care teams. The recommendation also tells us to follow protocols when we are using uterotonics, surgical endovascular intervention, or coagulant drugs. I'm aware of the differences in resources in different countries, and we try to focus on that possibly are also available in your country. We must be aware and early recognize postpartum hemorrhage and look for the reason of tachycardia, look of the reason of low blood pressure level. It might be secondary to spinal analgesia that is offered to those patients during cesarean section, but it's a very, very high risk of also that it comes from the obstetric massive hemorrhage. Different techniques might be used perioperatively, and our obstetricians put different kinds of techniques. Perioperatively, we also have experience with some endovascular techniques, which are not present in many Polish hospitals. Reboa is one of the options, or just putting a pressure over aorta when dramatic hemorrhage is present. Here's a protocol of using uterotonics, and first-line treatment is usually oxytocin. We consider carbetocin if not effective, or there is a risk factor for uterine atony. Usually small doses are effective if oxytocin is going to work. If not, we escalate therapy and use a second-line treatment. Methylergometrin is one of them, or prostaglandins in different ways. Would be great to have then options for obstetric patients. I hope it is available also in hospitals in your country. In order to treat hemorrhage, we need to have a substrate to build a clot. And this substrate is fibrinogen and platelets. That's why we need to assess those levels. Would be great in a high-risk patient to have those measurements done before surgery or delivery starts, because we know that a low platelets count below 150 and low plasma fibrinogen level less than 2 grams per liter are indicating population in risk of postpartum hemorrhage. We should aim with treatment to fibrinogen level which is higher than 2 grams per liter. That's the physiology, the bottom line of this line, showing that concentration of fibrinogen usually is increasing during pregnancy in the 3rd trimester, maybe even 3 times higher than a normal population, and these patients are safe. However, with any drop down with their fibrinogen level, we got increased risk of the peripartum hemorrhage. In the right upper corner, there is a shown volume of clotting factors in plasma, and fibrinogen is a major factor responsible for 92% of those factors. So if the patient is losing blood, the main clotting factor lost is fibrinogen. A few words about the technique which is not available also in my unit, my location. The university hospital has access to cell salvage. However, we know that it might be used and is well tolerated in obstetric settings directly. We don't have access to that, and we can use it with severe cases. It helps us to identify viscoelastic testing, reduced level of fibrinogen, platelets, also detects very nice hyperfibrinolysis. But the issue is, again, coming from McGregor studies, that majority of the obstetric units do not have a direct access either to viscoelastic test or cell saver. Many of them has no direct access to point of care hemoglobin, and 11% no blood bank, and 30% no hemoglobin point of care assessment at all. What we have as an assessment is APTT or PT times, which are not good to predict a postpartum hemorrhage, and also not to monitor clotting during surgery and bleeding, because usually they start to be prolonged when only 1/3 of the clotting factors are still active in our patients. Hemoglobin level, the left upper part of this graph, shows that might be falsely high until we replace volume. But when you look at the fibrinogen, the bottom right corner of this graph shows you that almost linear drop down with fibrinogen level with estimated blood loss. Fibrinogen is essential for treating obstetric hemorrhage, and we need to have a level at least of 2 grams per liter. However, a recommendation says against to preemptive fibrinogen replacement. I don't know whether fibrinogen concentrate is present in your countries. It was not present in my country for a long time, but now we have it available. If not, please use cryoprecipitate, because it contains much more fibrinogen than fresh frozen plasma, and also allows us to avoid many transfusion-related problems like trolley, trim, TACO, risk of infections. So if there is an option to avoid, use fibrinogen concentrate. If not, to supplement fibrinogen, use cryoprecipitate. This is a balance between costs and benefits. Not even from my country. Someone count the cost in euros for replacement of the same volume of fibrinogen, and it looks like it's very comparable. So try to think what is available in your country, in your hospital, according to your resources. And if there's an option, probably the best choice would be fibrinogen concentrate. However, I'm aware of it that it's not even available in every Polish hospital. And we recognize a difference in resources. There is a different document I'm showing now. It's a patient blood management data from Australia. Very nice documents, and I do encourage you to visit this web page and look what we should focus on. It's also mentioned in the European guidelines, and these are target values. So make sure that your patient has a proper temperature that has no acidosis, that has a satisfactory level of calcium. The platelets level is above 50,000. However, it would be nice to drop down below 75. Keep PT, APTT within below the range 1.5 of normal, and fibrinogen target should be 2.0 gram per liter. I hope tranexamic acid is present in any obstetric unit, because we know that it's a cheap, usually accessible drug that is life-saving, uterus-saving drug, and there is a strong recommendation coming from randomized trial to give 1 gram of tranexamic acid any patient, obstetric patient with bleeding, and there is a suggestion to use tranexamic acid and consider giving it in a high-risk C-sections or vaginal deliveries, even antepartum. The guidelines mention active factor 7, which we have experience with, and we know that it's a risky factor in terms of the risk of thrombosis. There is a suggestion to use it. However, our experience says when you focus on right level of hemoglobin, platelets, and cover all the elements that was mentioned before, calcium, pH, temperature, and platelets, usually we don't have a need to use factor 7A. Just a few slides summarizing this, what I have already said, coming again from the European perspective. These are the elements in red that we can think when planning treatment. So think about platelets level, tranexamic acid, blocking antifibrinolytic effect that is present in obstetric patients during bleeding, assess and supplement fibrinogen. Fresh frozen plasma is very uncommonly now used in our unit. On the major hemorrhages, we need it. Fibrinogen is covering that perfectly. This document consider also factor 13. However, we don't have a strong evidence supporting that, and it has been not mentioned in the European guidelines. Make sure that you monitor temperature, avoid acidosis, and focus on the calcium level, which might be decreased, especially when you perform red blood cells transfusion. Any hemorrhage, when treated, we need to balance risk of thrombosis. And if the bleeding is stopped and the patient is in stable condition, think about thromboprophylaxis. I will tell more about it during my next presentation. It might be mechanical, it might be non-pharmacological, but if there is a high risk of thromboembolic event, low molecular weight heparin should be administered 6 hours after surgery, and then follow. Think also about treating anemia, and we'll cover that. Iron supplementation, that's something we should start early, post-operatively. Some people think whether we should replace fresh frozen plasma, especially if not available at once, and we think about transfusion with prothrombin complex. We don't have strong data from obstetric patients. We have some information from other cardiosurgical fields, but we don't still have any strong recommendation for this use. However, sometimes it's the only factor we have at shelf, and we probably will use it. World Health Organization asks us to use patient blood management and focus on 3 pillars: before, during management, and post-delivery. And it's also covered by the European guidelines. Think about supplementation of iron oral. However, if you want to have a faster effect, iron intravenous supplementation gives you better effect and also improves fatigues and depression score postpartum. Again, a practice point when you think about transfusion with a stable patient. Majority of patients with hemoglobin level over 7 grams per deciliter do not benefit from transfusion, and we should think about other options. Usually, the problem with the patient and morbidity and mortality related to hemorrhage is not related to not having resources or not having the way of treating, but we delay diagnosis, we underestimate blood loss, we delay delivery of the clotting products, we do not follow simple instructions and recommendation, and that's the problem. We also have a problem with inadequate, ineffective communication, which generate delays on different area, also implementation of the standards of care. Crisis resource management in the obstetric operating theater. That's something that should be underlined and then treated properly, following these 15 rules shown here. Just mentioning another algorithm which comes from the United Kingdom, I want to focus on non-technical skills and designating roles and tasks: team leader, scribe, and runner. People who are not actively involved in treatment, but are very, very beneficial when you want to have a blood very early, when you want to have blood test results very early. It's impossible to treat properly patients without those. Just the last slide showing the algorithm coming from the German-speaking countries. They use a different approach, however, use similar interventions, which are mentioned here, focusing on the same targets. If you have an option, I encourage you to explore all these algorithms to find a right way for you. To summarize, an interdisciplinary approach allows to optimal treatment and outcomes. We need to be aware that it will be a crisis, and this crisis must be managed properly. Implementation of the guidelines in the national level would be nice to introduce, and also plan rational blood management, which will secure blood for those who will benefit for sure, and think about alternative approach for those who are stable. Thank you for your attention.